So we do a lot of, a lot of data cleaning, a lot of planning, but the main kind of core focus of our job is taking all these disparate data sources, taking all the business problems and trying to sort of connect the dots, right? Whether it's optimizing a current workflow, things like our radiologists seeing patients, things like the flow of patients kind of getting checked in, being able to know how much money should we collect from the patient, for example, for their deductible. So all of these problems are sort of at the intersection of how do we translate the complex data and the decision-making into sort of a transferable, understandable concept or rule or direction for the business. So what we found with radiology, and I think what everybody would agree on, is it's sort of the gateway into the healthcare continuum, if you will. So at a hospital, one of the first things that happens for somebody going through the ER, for example, is to get some sort of x-ray. If it's a car accident, perhaps they'll get a CT of the head. And that is the gateway to make the next care decision. So, it seemed like a sort of simple transition, or not too far of a transition, to get into things like emergency medicine, things like anesthesiology, pathology. What we found is a lot of the same patients that our radiology groups have seen are also seen by the ED, are also seen by the anesthesiologist. So some of the primitives there are exactly the same. So because we've built our platform in a generalizable way, plugging in some of the different CPT codes for that other specialty is really no work at all. So all the data we deal with, it's both dirty and disparate. So those are kind of the two hallmark ways you can define healthcare data. It's dirty because a lot of the ways, like we talk about in the emergency department, the way that a patient gets into the healthcare system is kind of in an emergent fashion. So perhaps they don't have their insurance card, or the people at the desk who are actually writing down the information about the patient, doing the intake, they're in a hurry. So they have a protocol perhaps not to enter the insurance information, or maybe there's a misspelling of the name. So that results in dirty data that somebody has to sort of make sense of, clean up, in order to make it actionable, in order to use it, because I can't send a misspelled name to the insurance company, or else they're going to deny our claim. So a lot of work that we do, and a lot of work in data science in general, is sort of cleaning and making sense of that data to kind of put it into one repository. Because once you have that whole episodic sort of data set, then you can really drive value by understanding, like we talked about earlier, the platform is from the scheduling of a patient all the way through the continuum of the cash being in the bank. Having that continuous sort of integrated data set is really important to drive sort of some of our algorithms, to drive some of the questions that our radiologists or our business people may ask. But when you combine our combination of the business folks with the deep understanding of the industry in terms of reimbursement, in terms of the clinical side, coupled with our technology folks and our deep understanding of how do we reliably, predictably, and consistently build process and software that is able to deliver on and optimize these folks' business. So when these groups plug into our ecosystem, they get the scale, the economies of scale, they get the technology, they get kind of the bargaining power in the industry that a big company like that would bring, but they get to remain independent, and they get to kind of keep the grassroots, local decision-making, they get to keep the relationships while being able to do their job better, being able to serve their patient better, being able to make more money, and being able to kind of not be a part of corporate medicine. So.